According to Kielhofner and Yerxa, two very well-known and influential OTs, the occupational therapy profession faced a lot of pressure to be more medical, so essentially more scientific, and actually away from its original focus on occupation. So to understand the shifts in current trends even in occupational therapy philosophy and theory and approaches, we need to go back into the history of how the profession was influenced by societal things and other professions even. As early as the beginning of the 20th century, OT has been influenced by many different theoretical perspectives. You're familiar with the medical model and maybe even the biopsychosocial model, but also there was the pre-vocational model, and it had its place in OT history, as you probably know in studying OT history. As for the pre-vocational though, a quote from a 1985 statement stated that only 2 out of the 34 curriculum directors at the time defended the work and evaluation and vocational rehabilitation. So maybe that's why it kind of fell out of practice. Let's take a deeper dive into the medical model now. The medical model has many strengths, right? Including its ability to explain scientific phenomenon into simpler terms that are understandable. It's how we got like the randomized controlled trial, which has really invented many things and advances in medical sciences. Psychologist Bruner believed that there are 2 general types of thinking: the scientific thinking or mind, also called the paradigmatic, and the narrative or storytelling. You're all probably familiar with the narrative, say from narrative reasoning, which is part of our professional reasoning as occupational therapists. Interestingly, scientific reasoning is also part of the OT's professional reasoning too, right? Among many other types of reasoning as well. However, one critique of the medical model is that it sees clients or patients, well, mainly patients as a term, in a sick role or as a sick role, primarily based on their symptoms, right? Another downside is that patients they seem to be taking a passive role in their participation. They're seen as passive recipients like in the hospital. How the medical model did positively influence OT in a way was its alliance and acceptance into the community, particularly the medical community. In fact, this is a really interesting history lesson. The AOTA at the time, they collaborated with the American Medical Association to establish OT educational standards. To further understand this historical context, one needs to be kind of aware of the influence that the Flexner Report had on the US healthcare system, even to this day, and how it has affected reimbursement. In the early 1900s, education for physicians, it was primarily it wasn't even really standardized. There were many for-profit schools, and there were really many ways to actually even become a physician and meet the standards compared to the more rigorous process that we know today. In fact, a lot of the medical schools at the time, they themselves weren't even scientifically based and included other diverse subjects in medicine, such as osteopathic, homeopathic, chiropractic, even botanical. So the AMA, they lobbied really hard for the standardization of medical schools, and they hired Abraham Flexner for the Flexner Report, who was really influenced by medicine and laboratory sciences and research and that kind of thing. So the Flexner Report, it had its pros and its cons. On the pro side, it standardized medicine and made it more scientific. On the downside though, it had many societal downsides in which it alienated minorities from becoming physicians. What about the Flexner Report's impact on other professions like OT? Well, this was used as actually very successful so that the model and its approach was applied to other professions. In the 1930s, the AOTA even asked the AMA to help them to establish standards for training and even to take over the accreditation of OT schools. By the way, this was back before the MBOCOT was established due to antitrust laws and stuff. This collaboration with the medical model helped to place occupational therapy in the field of medicine. However, you can imagine that the AMA at the time, they wanted to look out for their own best interests as well, right? And for physicians. So the scope of OT practice was essentially viewed as an ancillary medicine and was actually limited to non-medical practices and scope. Now contrast this with the biopsychosocial model, right? Bio meaning biology, psycho meaning psychological, and social social cultural factors. In terms of the spirit of the OT, biopsychosocial model aligns more with it, and it takes into account these 3 factors that are generally viewed as and believed to be more humanistic. The biopsychosocial is clearly distinct from the biomedical model due to the biopsychosocial being more holistic than the biomedical. One way to think about this is like the biomedical being a bottom-up approach, such as like looking at the symptoms, looking for disability, sickness, that kind of thing, versus the biopsychosocial, right? As you can imagine, it is more holistic and it takes a top-down approach. Now, think about the many theories that OT students learn about in school, like theories like PEO, MOHO, EHP. They're all considered to be top-down rather than bottom-up, as the components of like bio, the psycho, and the social, cultural are in the theories of these models and taking this more of a top-down approach. So in a way then, OT students are taught to be not biomedical, but instead biopsychosocial and therefore occupational. There are a lot of parallels there. Well, what is occupational? It's been defined many, many times, as we'll talk about later on, but occupational as in the engagement in occupations. It's even in the name of our profession, occupational therapy. So one of the founders of OT at the time, George Barton, viewed the goal for occupational therapy to be the creation of like a productive person, a more productive person. And early practitioners considered both the physical and the psychological in treating patients too. And throughout OT history, OT has even been defined and redefined. You all know that. We even see it to this day in the changing of our definitions, such as in the OT practice framework and like the new editions having like newer definitions. They stated that as a profession, occupational therapy, we are no longer a powerless, dependent child crying for the protection of the father figure, the AMA. Some believe that the movement away from this medical model allowed OT to reclaim the meaning of function and activity. Kind of like my motto, let's get functional. And this movement away from the medical model was towards the biopsychosocial model. Also, not mentioned were really other like influences behind the scenes, of course, just beyond the scope of this video, but things like societal influences such as like world wars, the politics, legislation, and social movements, right? One could say that the move away from the medical model began actually quite early in history. And it's not like a new thing to like OT programs these days. They're suddenly adopting like this move away from the medical model and focusing their curriculum on something else further away, be it a psychosocial model or a biopsychosocial model somewhere in between. So let's kind of remind ourselves is what's like the definition of occupation or occupation-based or occupational therapy. And it's defined by Fisher in 2013 as engaging clients in occupations as the therapeutic modality of change. Kind of like, what is that saying? Like occupational therapy as a means or towards an end, right? So let's fast forward in time to apply kind of like what we learned about this historical context given the discussion so far. And studies have shown that OT practitioners do value occupation-based practice, probably like right out of like OT school, right? But there is actually very little evidence of it being implemented in acute settings. One research article that I found showed that like one OT in that study, they spend like 80% of their time working on like preparatory activities, such as like increasing range of motion with the end goal only to support occupational performance and engagement. So this can kind of be seen as like 80% bottom up and only 20% top down. But anyone who works in acute care could probably tell you it's easier said than done, right? To actually practice occupation-based therapy. Let's start with the physical setting, right? Like the hospital setting is like very sterile, kind of uniform to meet like the accreditation standards. We have to have like infection control, right? Belongings are very limited. We can't bring outside food in, right? All the furniture looks the same. There's like minimal furniture for safety, so on and so on. It's not like the real world. Then there's the team, right? Doctors, nurses, technicians, other therapists. They're primarily probably medical model based. Not to mention the confusion and lack of understanding of the role of OTs by other professionals. Then in terms of practice, there's a focus on the fast pace, like movement of patients along and like discharging them, like come on, insurance, right? Insurance, or like lack of insurance, we got to get them out. So that makes it difficult for OTs to be occupation-based. Therefore, despite OTs like really wanting to value occupation-based practice, such as that and maybe even the biopsychosocial model, there are actually very few examples of it being implemented in the hospital setting, at least based in the research study. Some critics say that philosophically, the practice of occupational therapy does not even fit well with the medical model. occupational therapy practitioners often feel undervalued by the multidisciplinary team because, their occupational therapy perspective is not even like valued, well understood, or even respected or prioritized to be important, right? I mean, I kind of get it. Like, you got to keep the patient alive. Like, come on, what's their sign? What's the symptom? Like, what can we treat? What can we fix? What's wrong with them? And that's kind of like the nature probably of being in the hospital system. But now I want you kind of like step back and think about this. How well the hospital system and the American health system is doing. Not very well, right? If you were to compare it to other industrialized like countries and nations, despite the large amount of money being spent into healthcare, Americans have one of the poorest outcomes compared to the other industrialized countries. So perhaps the primary biomedical model that is practiced in hospital is not such a good model for the hospital after all. And OTs all along may have been on the right track with their biopsychosocial or occupational based approach. For a more balanced discussion, this is not to take away from the medical model, right? A world without the medical model would not be very good either. What can we all do about it, right? I don't have the, definite answer. It's not like an easy, quick fix, right? Our hospital system, healthcare system, American healthcare system, societal factors. There's a lot of moving pieces. If it was that easy, we would have solved it right away, right? So some OTs have suggested that maybe we adapt our individual practice based on the context and the situation by reframing how we think, right? Based on our theories and our models. Another idea is to explain to clients, we're probably already doing this, and educating them about our focus, especially if it's not in the medical model context. And like, why are they expecting from us to do if we're doing more occupation kind of based like therapy? But one idea that I really like, and a lot of hospitals are doing this already, is the environment, right? Just adapting and modifying and changing and like planning the environment and making it more obvious for our intentions, such as making it less hospital-like and more occupation-based. For example, like some of you may have been exposed to this, some of you are familiar, like mock kitchens or supermarkets or apartments, like literally in the basement of like a hospital or like a room that's adapted to make it look like that. So in those situations and circumstances, patients see it and they instantly get it. Oh, I'm here to practice this because I'm going to do this at home. So it's also kind of like meaningful to them. And that's all kind of cool part of OT. This, of course, has also like a lot of like, it's not so simple, right? It has like political, policy, financial, like barriers to it being implemented. Some have even proposed to focus on like the description, right? Like definitions, semantics, such as occupation rather than function. So perhaps maybe I should consider changing my motto from let's get functional to let's get occupational or something. So if you found this discussion interesting and you learned something, please give this video a thumbs up and you know what to do, subscribe and all that fun stuff for more occupational therapy content. Thanks for watching.